All right. Hello, guys. Let's see if I got all the stuff working the way it's supposed to in this room. So we're going to talk about pediatric obesity today, which I'm sure is everybody's favorite topic. I have like a love-hate for it. So it's a frustrating topic because it doesn't seem like we're getting any better at treating it. But I have some newer data today that hopefully will be at least interesting instead of maybe depressing. So we will start. I'm going to share my screen with you guys. Did I do it?
You did. Looks great.
This is hard work for me, this technology stuff. So we're going to briefly talk about some current guidelines with the new AAP guidelines that came out last year. But a lot of what we're going to talk about today is our specific patient population here in the North Dakota, South Dakota, Minnesota area, and some of the changes we've seen with the COVID pandemic related to obesity. So like we've discussed before, I would really prefer not to just lecture at you for the whole hour. So please jump in, make comments, make this more interactive. It just makes the hour go by a little bit faster and a little more interesting than having me just chat. So as far as disclosures, I have nothing to disclose. I have no active grants related to pediatric obesity research right now. So we talked about, we are going to look at sort of the etiology for childhood obesity. Why is it happening? Sorry, I just moved my screen off. That probably is not very helpful for you. So what are the criteria now? Because with all diagnoses, they seem to change with time and they update the criteria. And then the newer social cultural considerations were brought forth with that new AAP statement. So we'll talk a little bit more about that in detail. And then we will talk about the COVID-19 impact on obesity for our patients here in this area. So these definitions have not changed in a really long time. So to be overweight, obese, and severe obese, there's BMI classifications that we all know about. And sometimes those auto-populate for us in our, if you're using Epic, depending on what kind of an EMR you're using, sometimes those will auto-populate for you. But the classifications here are what we're going to use in terms of this research that I'm going to talk about in more detail. So the new practice guideline that came out, I'm not lecturing in person, so I can't ask for a show of hands, but I'm hoping that you guys have read it. It is not a short document by any means. It's a really long document. And there's pieces that I really liked. There are pieces I really didn't like about it. But I think there was a lot of effort put into trying to define obesity correctly in this day and age. And so they talked about, being a multifactorial set of socio, ecological, environmental, and genetic influences. So basically saying our whole world and our genetics impacts the way we grow and the way that we eat food. I was really disappointed, though, when they didn't talk about prevention or really looking at evaluation or treatment for children 2 and under, like that group where we can still maybe change how they eat. They didn't really talk about that. And I think I was just biased because in my clinical practice, I take care of small children who don't eat very well. So I spend a lot of my time educating on healthy ways to teach kids how to eat. So overall, and this prevalence is from a CDC data pre-COVID, was that 19% of kids between 2 and 19 are obese, which is a lot of children. This was a 3 times increase from when they looked at the 1980 data. And then they discussed that 12% of those children, their BMI was over the 97th percentile. So a lot of children that we're dealing with. I'm sure if you are in primary care, you are seeing children every single day. There probably is not a day that goes by that a child does not walk into your exam room that would classify as obese according to their BMI. With the increase, now this was data before COVID, it says if the model stays stable, so if our predictions of how quickly we're all becoming obese stays true, 57% of the children will be obese by the time they're 35, which is a shocking number to think about handing that to our colleagues in family medicine and internal medicine, these patient populations that's all they're going to talk about in their clinics. So I share these specific breakdowns because later I'm going to show you our data from our COVID project. And so I want you to see sort of the breakdown of children's ages and how likely they are to be obese. So the 2 to 5 year olds, this was the 2017 data pre-COVID. They had no increase from the 1999 data with obesity. So I was pretty excited about that. Not thrilled that 13.9% of those children would have a BMI greater than the 95th percentile, but excited that there was no change for that age group. But then again, we did see from, the ages 6 to 11, they have a higher rate of obesity, and then the increase was high, almost the exact same for 12 to 19. So really high rates of obesity and continuing to climb with time. But those 2 to 5-year-olds seem to just kind of hang, which unfortunately, I'm going to show you some other data soon that's going to show you that's not true anymore. So briefly touching into some factors, like how does this happen? So we know that change from the 1980s data to now, one of the big changes is the way that we feed our children and the way that we snack. So there were no prepackaged snacks in the early 80s. Children did not have an option to go home and get their Costco size bag of all these lovely things that make it so easy and accessible to eat high caloric, pretty nutritionally depleted food. But it's not hard at all now to say, I'm at Costco and I'm going to order myself the box of all the random chips or the Cheetos or whatever it is. I do that for my children. So I'm not judging the whole world. I'm saying there's convenience that's been added in. So we know that that's happened. We also know that the United States was really excited about supporting sugar and some of our nutritionally sound foods. The government was giving some tax cuts, and there was some motivation there to make us all want to eat those foods a little bit more from a government standpoint. Looking at neighborhoods and communities, we know that the world that we live in gets more unsafe all the time. So children who would, run free and be biking till the streetlights came on, that changed over time. And obviously, the more urban you live, the more that is going to impact a child as well. And then obviously, like those home and environmental factors, like our kids these days are on too many screens, and they don't sleep very well, and they don't move anymore. So there's just a lot of changes that would shock somebody if they looked at childhood in 1980 compared to childhood today in 2024. Which I tell my children all the time, and then they just call me old when I bring that up, because I say back in my day. But it's true, we didn't have access to those things. There are individual factors, thinking like there's genetic factors. There are people who do have a propensity towards obesity early on. We know there's prenatal risk. So maternal weight gain, gestational diabetes, those things will impact the way a baby grows. Breastfeeding. I don't know so much if it's actually the breast milk or the fact that when you breastfeed a baby, your baby can stop and start when they want, and you have no idea how much they've taken. So there's less pressure to continue to finish that whole bottle. So they maintain their hunger full cues a little bit longer when they're breastfed than when they are fed strictly by bottle. And then obviously we have other childhood risks. Our kids are unfortunately victims of trauma. There's other mental health problems. Sometimes there's some psychiatric medications we use that will change the way that our bodies grow. So knowing all these things, knowing that the kids live in a complex world with not as much movement, too much screen time, too much processed sugary foods, we already knew we had a problem. Like the whole world was aware we had a problem before COVID. And then in March of 2020, we quickly had to shut down access to schools. That was our government's approach to the COVID-19 pandemic. And at the time, we were thinking about, transmission of the disease. We were not thinking about the secondary health consequences of keeping people inside. So I was curious. I worked with a couple people through NDSU, and we had some medical students who were just really interested to see what happened to kids when we kept them at home. And did it change at all if we were living, in a town like Fargo, or if we were living on a farm in Williston? Like, depending on your COVID-19 strategies, we all know that our Minnesota kids stayed locked down than our North Dakota kids. And we were just really curious to see, does this impact obesity? So we took a peek at a couple years pre-COVID and a couple years post-COVID, looking at BMIs, really interested to see, knowing that, we have an increase in screen time. We all had more time on screens when we were parenting children from our houses. I am positive. I was in this hospital every day, but my husband was attempting to be an attorney at home with 2 children. They learned about iPads, and so we haven't ever gone back since then. And a lot of families did, because we had to balance it all. It was just this natural thing that happened. High salt foods. People started looking for convenience foods, things that were easy, things that were packaged, things that could be delivered to their homes. There's a lot of grocery pickup. There was a lot more sugary drink consumption during that time, and a lot more alcohol consumption for adults, which we're not really sure how that plays into our childhood obesity yet, whether it's, an increase in alcohol consumption results in maybe also an increase of screen time and more sugary food for their children during that time. That hasn't been teased out in the literature yet, but we know all of those things increased and physical activity decreased for most people. And even just natural physical activity, like our children, riding their bikes to school and going to recess and going to gym class. The 5 minutes of like the Zoom gym that they had to do was not comparable to just their activity in the building every day. So we knew that happened, but we weren't really sure, like, did it matter or did it not matter? So we were looking at this right around the time CHOP, they beat us. They published before we did. So we were looking at this ahead of time and we were like, does it matter? Because we kept thinking in our mind, our North Dakota families, we were still outside. We have yards. I think of the difference of now, like I have, a big backyard that I live in. And when I lived and practiced in Baltimore, I had a row home. My children would not have been able to go outside. We kind of thought we were immune to the changes here in North Dakota, but the data is going to show you that it wasn't. So we looked at over 200,000 pediatric healthcare visits. So this was any pediatric visit between the ages of 2 to 18 that occurred in a Sanford health system in Minnesota, South Dakota, Iowa, and North Dakota. So we looked at January 2018 through January 31st of 2022, because we wanted to see what was like before the pandemic, during, and then after the pandemic. So we categorized those visits into these different dates, hoping that we would see sort of a trend. So this is a lot of data, and I'm going to only just summarize the parts that are interesting. But going back to remembering that our 2 to 5 year olds hadn't gained any weight during that last CDC data, that data haul they did, it was interesting here. That's our green square here. The 2 to 5 year olds, 11.65% of our Sanford Health population was considered obese prior to the pandemic, which is actually a lower number compared to the nation. So I was a little excited about that. I don't think it's statistically significant, but it's lower. But we also found that those children had an increase in obesity during COVID, which makes sense. A lot of them were probably out of daycares, they were out of preschools. And we know that those types of educational centers capitalize on active movement and active play. And as parents, we sometimes, when we're home and we're trying to work from home, there's just more TV that comes on for that 2 to 5 year old age group. The exciting thing about this, which is why I've highlighted it in green, is that post-pandemic, those children returned to their regularly scheduled programming. So really, they were back to the regular obesity rates we saw pre-pandemic. They were the only age group that did that. So if we take a look at our 6 to 10 year olds, pre-pandemic, 21% of those children were obese, which unfortunately is higher than our national average. And then during our pandemic period, 24.8% of them were obese, and that number stayed the same. So they did not return to their regular rates of obesity. They stayed the same. Our 11 to 13 year old population, we broke those groups a little differently because we were thinking of a middle school versus a high schooler that maybe had a car and maybe wasn't following all of the same shutdown rules. Our younger kids without transportation were, we found 28% of them were obese prior to COVID. It increased to 29%, and then it continued to increase. So that really fits that prior model where every year it seems to get a little bit worse for that age group. Same thing with our 14 to 18 year olds. So we were a little, well, I was sad, I'll be honest, like usually data doesn't make me sad, but I was really sad to see that once the world opened up and we got back to school and back to activity, that we couldn't stabilize and those numbers for any of our kids. So this is where I'm hoping that we can have some conversation about this. Have you guys noticed in your actual clinics this sort of a trend? Do you feel like more of your patients are obese, or you're fighting more of the excessive screen times or excessive snacks than you were pre-pandemic? Or has it not changed anything in your clinics? Should we just do the awkward moment of silence longer so someone answers? Nobody? I think it's worse. So, I specifically only take care of children who have feeding and swallowing problems, but I feel as though the snack epidemic, is what I like to call it, is worse post-COVID. I feel like children have more access to frequent snacks, and they don't leave home without them. So I think some of that has changed over time. And I think the technology addiction worsened during our COVID pandemic. And I feel as though there's more parental report that they're having a hard time taking those screens away than pre-COVID. So I think it's sad to see kind of where we're at right now. But these are data that I thought would be helpful to share because these are our actual Sanford patients. This is not like a CDC study of, children that are in, inner city New York. These are the kids who live primarily with our areas. Looking to the one other thing that I thought was interesting is I really thought that our rural children I don't know why I thought this, but I was hopeful that those kids who have access to yards and like maybe live in a more conservative environment that didn't have shutdowns, we would see a different trend for those kids than we did with our urban kids. But obviously we see that they had a higher rate of obesity at baseline. It increased and it stayed the same too. So that was a little disappointing. And you could make an argument that there's a slight decrease in obesity for our urban kids from the pandemic to post-pandemic period, but that is not at all significant. So it's roughly the exact same. So I was just surprised at thinking that we actually did a few more analyses too. We looked at insurance type, socioeconomic status, racial background, and also if you lived, we broke it down by zip codes, and we looked at each school system's pandemic response to COVID. Those who shut down longer, there were no differences with that. So it appears just having the change in March that happened was, no matter what your school system did as far as return to entry, it didn't seem to change our obesity trends. Any questions about that data or things you guys want to talk about? Okay, we'll move on. So we already know that pediatric obesity is a problem. It's worse now than it was before. So what are we supposed to do about it? If you have read the new updated AAP statement on it, there's a lot we are supposed to do about it that I haven't really figured out how to do yet, but the task in front of us is large. So number one, we have to get better at assessment and identifying pediatric obesity. So right now, the data shows that we really only catch about a quarter of those kids in clinic and have a conversation and an action plan. And it's really shocking too that the parents that are surprised by the fact that we're bringing it up, a lot of times they just don't identify that their children have a problem with weight, because more than likely they also do as well. So their tolerance for different weight levels is just different. So we find that typically the older the child, unless they have severe obesity, the older the child, the more likely they are to have a discussion about weight. And really it is those kids who have like shockingly high BMIs where you have to say something in the exam room without leaving. The kids who we should be saying something about, oftentimes we are avoiding that. And there's a lot of reasons for that. So we talk about like what, not taking the extra 5 minutes in the room to talk about BMI trends. It's uncomfortable to talk about weight in front of parents with children. I mean, it's just uncomfortable to talk about weight. But by not talking about it, there are consequences because we're missing opportunities to intervene. And we know that we need to intervene at early ages, or we really have sort of lost the fight, which is pretty sad. So looking at assessment, we recommend now, I'm not the AAP. The AAP is the we. They are recommending that at 24 months, we start talking about obesity using BMI as your gold standard measurement. So that's a challenging one because a lot of times at that 2-year well visit, if you would say, well, little Johnny's growing up here, he's a well-grown little guy, he's growing up here at the 97th percentile, parents are a little unhappy to hear that. And usually the response is, well, they're just a little, what am I supposed to do about it? They're a toddler. So the question then is like, let's break down, how are they growing? And what we find often is that these are children who like to snack frequently. They want to snack in the car everywhere they're going. They want to snack after dinner at night. They want to snack before bed. And we find out they're like having 7 snacks a day. So instead of talking about weight, we talk a lot about like, let's talk about your diet. Because breaking it down and saying, you know what, I bet your kid's going to eat a little better at their meal times if they only had like 2 structured snacks a day and they weren't allowed to free snack. So you're sort of fixing some of that toddler pickiness, but really your eye is on the prize of let's make sure this kid stays at a healthy weight. And we can do that better by reducing the number of snacks. I'm lucky that I have a dietitian in my clinic who has fancy little calculator she uses. So we'll be seeing a family and they'll say their child doesn't really eat a lot at meals. They don't know what to do about it because they can't go unfed, but the child's BMI is at like the 99th percentile. So we all know they're eating something. And it is not abnormal for her to get done with a day's diet and tell the family that the child's eating 700 to 800 calories of like goldfish crackers a day. So when you're a toddler, you don't need a lot more than that per day. So it's sometimes just talking about food from the lens of a picky eater is a way for you to sort of step into some obesity work without offending families as much. Another very important thing to do is talk about food insecurity. I know like our Sanford pediatric clinics, we have a food bank, which is excellent and it's really well used, but a lot of families really struggle with access to appropriate foods for their children. So it's an important thing to talk about, and not just talk about, but then hook families up with resources and different supports. Screen time assessments. I know we all talk about screens and families will underplay how much their kids are on screens, but I think it's really important in that under 3 groups, or even under 5, to talk about how important it is to really limit your screen time for your kid. Because when you are playing a screen, it's competing with your child's ability to want to go outside and play, or even just play within the house where they just move constantly. Small kids like to move. They don't, but they sit still really well when they have an iPad in their hands. So we're losing chances for activity when we do things like that. So you're supposed to take a focused family history. We used to have a coordinated obesity clinic here at Sanford that kind of went away a couple years ago around the time that Ozempic came out. And a lot of our families, we would do our focused family history and talk about obesity rates for the family. And families would usually say nobody else in the family was obese, but mom and dad sitting in front of us were clearly obese. So it was very interesting to see just perception too when you're trying to do that family history. A lot of time families don't identify it as well. So we do know that if both parents are at a nice healthy weight, children are less likely to become obese as adults as they are if their parents are overweight when their children are young. Other things to think about too are developmental considerations. So we know that kids with special healthcare needs oftentimes are at a higher weight because they have less physical activity, or they maybe have some gross motor deficits that make physical activity hard. And there are times where we are feeding maybe more calories than that child needs, especially if we're using an enteral feeding tube, or maybe a child's on formula a little longer and maybe we're fortifying longer than we need to. So we need to just be conscious of thinking about a child's physical abilities and making sure we match their nutrition with those physical abilities too. Trauma. So kids who've had, any of those adverse childhood experiences, we know that when you start adding the numbers of those up, the rates of binge eating increase for those children, which is something that is important to target early on as well, especially those children who've had food scarcity. Maybe the trauma has involved not being fed by a caregiver or not having access to food as a punishment. Those children will often eat to excess when they have access, and that's more related to just the trauma. So that's just something to pay attention to as well. And then we obviously start lipid evaluations for kids at age 9 for their routine visits, but for children with severe obesity, I encourage you to do that earlier between the ages of 2 to 9 as well, because unfortunately those kids can have hyperlipidemia and those obviously have long-term consequences. So what are we supposed to do? We have all this work to do. The AAP has this giant, 100-some page statement. They want you to have the conversation, which sometimes can be the hardest thing to start doing, which is why I like to come at it, which is probably cheating to come at it this way, but I come at it through, is your kid hard to feed? Are they a little picky? Are they good at fruits and vegetables? And we work into, by doing these things, we can hopefully make sure that our adult bodies are as healthy as they can be. And we start having these conversations in positive ways. We talk with parents about, what's impacting your ability to make some of these changes right now. And then some of our families have zero readiness to change, and others are like, we are ready, we don't know what to do. And those are the families that we would have a different plan because they're coming in ready and excited about change. So this is a figure that came out of that new AAP guideline that talks about this gold standard care. And I think it looks beautiful. I don't know where we can get this care yet outside of an academic hospital. But right now they want you as the pediatrician to partner with the family and a community organization of some sort to have regular follow-up for these children so they can meet their goals. So they talk about, shared decision-making that we're doing with families, culturally competent care. These children should be in medical homes, according to this new AAP statement. And then how do we get them from, day one where we're having this conversation to managing this as a chronic disease? And I fully agree that obesity is a chronic health disease and should be managed in a chronic care clinic. I just think the disappointing thing about this new recommendation to me is that it doesn't feel useful for those of us in a clinic alone without having, we don't have a medical home nurse and social worker for every child with obesity. We just don't have those resources right now. So I read this and then I just felt a little defeated that the thing that's obviously best care is something that I know I can't do in my clinic, and I don't know who can. So my goal is to try and take pieces of that and see what we can do with it, because we just don't have those resources. So I think thinking about it like chronic disease is helpful, because we know that chronic disease is something that we treat. I mean, if you have diabetes, we are going to take care of you and treat you for the long haul. Same thing if you have asthma or other chronic healthcare conditions. So we need to think about obesity that way, which often means more visits than the standard well-child visits to talk about some of these goals. And then using our motivational interviewing strategies to get families to accept this obesity as a chronic healthcare condition that we want to manage and successfully treat. So this is the model that they want us to use, this intensive health, behavior, and lifestyle treatment model. So you're supposed to have a multidisciplinary team, and you're supposed to see this child fairly promptly. One of the papers I read recommended, every 2 weeks to every month, which is, I think, probably the right dose of treatment to make changes. I don't know anybody who can get these kids in that reliably in a primary care setting where they're only doing this. There are great pediatric weight loss programs in the country at academic hospitals, and they see their patients very frequently. But this was really written for more of the primary care provider. So they were hoping that within this model, we would have, behavior modification and counseling with mental health professionals, like nurse navigators to help teach some of these lifestyle skills of, having healthier meals, adding more fruits and vegetables and protein. And they want to be able to do this in both your PCP clinic as well as a community outreach center. And they would like you to be seen ideally 26 hours across 3 to 12 months, which is a lot of clinic hours for a primary care doctor. So we know that pieces of this don't work great for us right now, but it doesn't mean that we can't think about how we do it in our own clinics. Do any of you specifically treat adolescents or small children who have obesity as your primary treatment concern? Okay, well then you're lucky. This does not apply to you. You do not have to try and figure out how to package this, but I'm guessing you work in settings where there are children coming in with obesity, because it's a large percentage of the children who we treat here in this area. So these are things to think about as far as our community resources. Sanford Fit has a fitness plan. There are a lot of things that you can do from a community standpoint if you have resources. But for our families who are underserved and underprivileged, it's challenging to be able to access some of those things without having an income to be able to buy memberships. So it's tricky. So that leads us to what we can do pretty well, which is medication. So I would say, I don't know, even 10 years ago, the thought of using a medication for a child for weight loss really wasn't, it didn't sit well with a lot of people. I mean, obviously we use things like stimulants where children could maybe benefit from a stimulant from an academic standpoint, but also would probably benefit from some appetite suppression, and they were used that way. But not a lot of providers were then saying, you know what I want to do? I want to put a child on metformin. Or the thoughts of using any of our GLP-1 medications. But we know that a lot of the big academic weight loss programs that are running these clinics are using medications very successfully, and it ends up being the deciding factor in treatment success for a lot of children. So I know we do have children when we were still working in our obesity clinic, our multidisciplinary clinic, who were, they were just starting to filter in on things like Ozempic. We would have some families who, they had come to our clinic for 2 years. We see them every couple months. no change. They went to a med spa, family had resources, they were able to find some Ozempic, and their child was finally seeing some weight loss success, which then I think changed a lot of how that child decided to approach the rest of these goals that we had. Our goal with our exercise physiologist was more attainable because we were feeling a sense of success. But those initial children where we saw BMI drops were children who had a lot of privilege and a lot of other supports around them. You know, families were like, we're going to buy a Peloton for them and get them a wellness center membership. And they were set up as best as possible. And the medication was a supportive tool to use in the process. So now we're starting to see it with, it's widening as far as insurance coverage. So we're seeing other children have access. We know there's a host of side effects that happen, like there's delayed gastric emptying, there's nausea, but a lot of the kids who've been taking it that we have talked to within our clinic were still so excited to see some weight loss that they were going to persist with it. We don't have a ton of long-term data yet on what this is going to look like, but they are FDA approved for children. And so I think this is the way the world's moving. So it'll be interesting to see what happens as we go. But I know the adult weight loss clinics have been using medications for a very long time. The other thing that we are seeing more and more of is our weight loss surgeries, instead of thinking of them as a failure, which really was, I would say 10 years ago, what we thought of. If we had to send a 16-year-old over to talk to a weight loss surgeon, we were like, well, I guess things have gotten that bad, you better go, without thinking about using them as a tool to be able to make a giant difference for these children. So there are surgeons in certain weight loss clinics that will see children over the age of 10 for weight loss surgery. These kids do need to have, you know, morbid obesity along with other co-occurring health conditions. And they're finding that no matter what BMI these children start at when they have surgery, we see a reduction of about 30%, which is a shocking number if we think about it. And so those children who maybe were not morbidly obese yet, but were on the way there, very successfully on the way there, but maybe haven't developed type 2 diabetes or hyperlipidemia or any of these other secondary health complications, we were able to stop that in its tracks and reduce those risks for those children. Now, it is not without other risks. Obviously, we know that bariatric surgery is a big undertaking and something not to be taken lightly. But I also think we sometimes used to reserve it for, you know, more special cases, and other children who could have benefited were probably missing out. So the risks, you know, that are associated, obviously, we know they have micronutrient deficiencies. It's really hard for those growing bodies to get all the nutrients they need after bariatric surgery. Higher rate of fractures. The skin piece that kids don't think about. We've had some kids who've lost a lot of weight on like Ozempic, and then they're super upset from a body dysmorphia standpoint because they're like, I still have all this excessive skin. I don't look the way that I thought I was going to look. So there's, you know, other surgeries required for that. And obviously we know from all the research that bariatric surgery does put you at risk for, you know, alcohol and substance abuse down the road, as well as an increased post-surgical loss of control eating. So in other fancy words, more binge eating after surgery than before. So to close things out, we know that obesity is a problem that we're going to face forever. We live in the United States, and this is a place where we eat a lot of snacks, we eat a lot of processed food, and we really love screens. And that's not changing anytime soon, unfortunately. We need to think about it like a chronic health condition, something that we have to manage regularly and routinely, not just at well care visits. And we also need to think about treatment as a comprehensive piece. So lifestyle change, we always tell people, you know, you want to lose a little weight, you should probably just eat a little less or walk some more steps. But for a lot of these families, there's so much more to it about changing the culture and the way a family functions that we often need to bring in more supports, behavioral health supports, exercise physiology, social workers. There's a variety of people that are really good at helping families make those changes. And then not putting those ideas like medication and surgery as a back pocket treatment alternative, but thinking about them as, you know, really successful treatment options for some families if it's the right family. So just want you guys to think through those choices a little bit. So these are some resources that you guys can look at. But I encourage you, if you haven't taken a look at the new guidelines from the AP, to read it, look at it, and figure out. I had to read it a couple times because the first time I read it and I was just a little not very happy. But when I read it the third time, I was able to pull some things from it that said, I could use these things in my clinic, or this is a good idea, when I was able to break it down. So I encourage you to do that and try and figure out what from that new guideline could you use to make your practice a little bit better. So questions or conversation or? Okay, there's one in the chat that was like, overweight and obese patients are a struggle. Yes. Parents can be hesitant to have a conversation and they have excuses. This is how they're built. They're just like their dad. That's completely true. I mean, we hear this all the time. And it is easier to excuse away things than to truly think about our day-to-day activity and how we function and if we are doing the best we can, because there's a lot of things that come at us every day. As a parent, we need to go to work, get our children to school, get them to their activities. Are they eating healthy? And usually in this day and age, it's a 2-parent working household. And so things just get even more challenging as we go. So I think the excuses they come a little faster than they used to because it is an overwhelming time to be a parent.
Hi, Carrie. This is Gail Kerber. I just wanted to jump in and thank you for giving such a great presentation here. Really important topic, really difficult topic, particularly in light of these recommendations coming forth. I'm one of the psychologists that works in the outpatient eating disorder and weight management center here with Sanford. Specifically work with adults in our weight management program, so potentially the parents of some of these kiddos. And so understand the struggle about kind of talking about some of these recommendations and how do we kind of reconcile them. I think a lot of the chatter, dare I say, in this area with these recommendations as they come out is at what point are we putting kids at risk for potentially developing an eating disorder later down the road with some of these restrictive behaviors. So just wanted to see if you had any thoughts on what you found to be helpful in particularly addressing that kind of concern with parents should they raise it in the room with the kiddos.
That's a good question. So I feel like a lot of what it's the language and the presentation and the modeling in the family. So for a lot of our families, I mean, the best thing you can do to make your child a good eater is to have structured meals during the day and not free snacking. And just know that these are the times we eat. Just like kids who are in daycare, they know when their meals are and their snacks are, and they eat during those times because they know this is when the kitchen's open and when the kitchen's closed. And it has nothing to do about the child's weight, about whether they were good or bad today. It's just these are open feeding times during the day, and everyone in the family does it. And 50 years ago, we all knew when our mealtime was. So a lot of times I talk with parents about if we're going to take the snacks away and start doing this more restrictive model, to not think about it as restrictive, but as what the entire family should be doing, because our bodies eat better when we eat at structured times. So if we come to our meals hungry, I'm more likely to eat the salad or the vegetables. But if I just had a snack, I'm probably just going to eat the taco and leave the salad. Like there's those sort of pieces with families where when we have mom and dad joining in, as we all want to spend more time sitting at the table with each other, and our snack time is at 3:00 and I'm going to have a snack with you too, it goes better than those families who are like, well, little Johnny, you weigh too much, so the doctor told you can't have any snacks today, which is what we often hear. I will hear this in the exam room too. They're like, did you hear that? The doctor says you can't snack, but yet mom is eating a snack. And it's like, or she has a 400-calorie Starbucks with her. And I was like, well, this message we're sending isn't about the volume of food. It's about the fact that we need to have meals happen at a mealtime and then go play. So
Sure.
It's different language to think about a whole family trying to function better and have more healthy mealtime behaviors than about restricting the calories. That comes with having less snack times. So if you can't have a snack, you're going to go play.
Yeah, I think that's a really great point and kind of a very nuanced difference in the language, but not using kind of the words restriction and more about kind of almost lifestyle balance, right? Or kind of coming up with a pattern that feels more balanced and is more suitable to maybe helping you get some of the physical activity in and the eating patterns in. I think that's where a lot of the misconceptions are in terms of the weight management side of things in terms of these programs aren't really promoting pure just restriction and that's it in terms of food. It's kind of more comprehensive in that way. And so I really like that kind of suggestion of kind of focusing on the full comprehensive piece and not just on eat less calories.
Yeah, and families should eat their meals at a table together. There will be fewer screens at a table. All those things that, I mean, you get to hear the weird stories about your children during the day if you eat a meal with them, which I am fully aware gets a lot harder. Like I had to laugh at my schedule with my kids this year. We found 2 workday weeks per week that we can eat as a family. And I was like, I guess I should be excited about that we got a Monday and a Friday. But between activities and everyone's different sports schedules, it is challenging. And when you don't eat as a collective family, the scheduled meals start disappearing because people just eat. We're eating and we're not eating because we're hungry. We're eating because I won't get to eat in 4 hours.
Sure.
And that breaks our hunger full cycle that we were really good at the first 15 months of our life.
Yeah.
It's just a lot about, I think, the way our society functions, which is sad. Yeah, nobody likes what they call us the snack police. But I'm like, I'm not the snack police. Our job is just to have you eat your fruits and vegetables so you don't get scurvy, because we get a lot of scurvy in our clinic. And so and the other piece about some of those things too is that I am the snack police because it comes like my kids' sports activities. I don't know how many of you have young children, but like my son will play hockey and then there's a snack schedule. After every single game, parents have to bring snacks for the entire team. And when he was little, really little, when he was 5 or 6, I promise you, they were not expending enough calories for a snack. These kids were on the ground, couldn't get back up on their skates. Like they would just lay there the whole game. But there was always a need. And these were the giant Rice Krispies and a Prime for 5-year-olds. And I was like, what has happened to like the day when, I think about the 80s and we would finish softball and some mom would have brought like apples or oranges.
Orange slices. Yeah, something like that.
Something like that. Or that would be like the big day is when they started making the pre-cut apples in the bag. That was like pretty classy stuff back then. But that just isn't a thing that happens anymore. There's an expectation that if I did this thing, I should probably get a Pixie stick and a Rice Krispie bar and a Gatorade. And we've paired everything with food.
Yeah. Definitely. The year-old contingencies at play there for certain.
Yeah. So it's tricky. Anyone else have any thoughts or things that you guys have tricks you figured out to make this any easier?
I allowed fruits and vegetables for free game. They could have those at any time without asking. So that's.
Did they pick them? Did they pick the fruits and vegetables? You knew they were real hungry then, didn't you?
I have to say, my kids and now they're adults. One actually turns 20. My youngest turns 21 tomorrow. They definitely are unusual eaters. Like they are very, very healthy eaters. In fact, my youngest, we more had problems with the opposite, her constantly being underweight and having to beef her up. I remember one time telling a doctor that she would drink the little coffee creamer if I let her, and he was like, let her. And then a dietitian saying there are no bad calories because she was there. The dietitian asked her favorite food and she said salami, but mom won't let me eat it that much because it's bad. And the dietitian said there are no bad calories. She can eat whatever she wants.
Yeah,
so
there's no bad
okay,
food,
but I want a healthy adult here. I'm not thinking just the next like 6 months to get her at weight. Like
you're thinking like as adults we can't have that much processed meat anymore. They tell us we can't, right?
Right. So yeah, although I will say one thing that was really interesting is I've struggled with my weight my whole life, and I have an older brother. My older brother is 6'4", 160 pounds. So
you got the genetic
difference between us. And so interestingly, my girls got his genetics and his attitude about food. So like my daughters will admit that they only eat because it's a necessity and they really don't care about food, But his daughter got mine. And it was very interesting having grown up with him as an older brother, just 2 years older than me, and his attitudes about my weight and all of that throughout childhood, for him to all of a sudden have to do this shift when he was no longer in brother make fun of mode and now
Yeah.
parent how to manage my daughter mode.
Yeah.
And it really weirdly shifted my brother and my relationship as adults, because he then came to me and said, how do you wish this had been handled when you were younger? How can I support her struggling with this, and so it really shifted our conversations. And I will say, like, I did provide to him a lot of feedback on, because particularly being an overweight kid in the 80s was not a healthy time. Like, we had a lot of like negative concepts about it, and this is the time of like Weight Watchers, and so like a lot of it was just some real unhealthy. And so helping him learn to work with his daughter on that, and changing that conversation for him. So it's very interesting. And I'm happy to say she has been very successful. A lot of it really was working less on the food stuff and more on the activity stuff. Like making sure, like having activity, like you said, shifting the access. If you're really busy doing a lot, then food isn't as much of a focus. And
no, and I tell that to families a lot. I'm like, think about those days you're busy and you're running errands. Did you eat during that time? And they're like, well, no. And I was like, because you had other things to keep your mind on. The tricky part is that it's with as the demands get harder at parenting. Yeah, they're harder, they're just different. I'm sure it was incredibly hard to parent during the Great Depression as well, but as it's different to parent, I just think over time as parents, we're like, okay, you got to go outside and play, but I'm just going to sit here on the couch. And we are equally as distracted by our technology as our children are. So having those meals where nobody has a piece of technology is very helpful. Like, my kids love to call me on that. Like, if I'm at the table and I get, a chat from the hospital about a consult in the evening, they'll be like, no phones, mom, because, it's fun to make fun of mom during about those rules. But a lot of parents are just like, well, but I'm the adult, so I can do these things. But they forget that they are modeling the behavior that they want their children to then have, and they're not doing it very well. So when I tell families, I'm like, well, you could all go out on a walk. The parents are like, I don't want to go on a walk. I don't know where to start from here if we don't want to take our kids on a walk to the park. Like, that's a pretty natural parenting activity. If that's too much work, I don't know what we're going to do. In a place like Fargo, like when I practiced in inner city Baltimore, you certainly did not take your child on a walk around that hospital, that you were just going to get shot. So I wouldn't have asked that. But in my neighborhood in West Fargo, there is zero reason why you can't get up after work, walk to the park, and push your kid on the swings for a little bit. But it's like pulling teeth to ask them to even make that change. So it makes me feel hopeless when I think about the treatment of obesity, when even something as basic as a fun interactive activity with your child, which will make them go to bed better at night if they played outside, is still just too much effort. So it's a lot. Any other comments? Or
here's Melanie had a question.
Oh, I'm trying to read it, Mel. I'm old, so I got glasses. Oh, you are not a lowly Nick. Now we're gonna have words later about this. So if I'm understanding this correctly, your question is more like, is this the right curve to use still? Is that what because there is an extended BMI curve that pops up for children who are obese that's above the standard.
No, I don't mean the one that, I don't mean like using a different curve. I'm just wondering, like, the curve that we have, how are the numbers decided? And if the kids are overall bigger, are those numbers then changed periodically? And again, maybe this is like normal knowledge, but are those numbers then changed? And so how does that affect what we're really looking at?
Yeah, no, from my knowledge, they are not changed, because the curve we use for children is based off of the World Health Organization, not the United States if we were to make a growth curve of just the United States, we would need some very different average numbers if we think of that bell curve. But we use the World Health Care Association, their growth curve at this point. So I don't think those have been updated in a very long time.
Sure, that's what I was wondering.
Yeah, I think it's correct, and I have a love-hate with the growth curve. Like Mel, I take care of your little buddies, and so the kids who come out who don't eat well have been in the NICU, and those babies aren't even on the growth curve, but they can have appropriate fat stores. We can pinch
Well,
like
even my own kids, right? They are small, and so
but
I do give them access to snacks all the time, right? So
you have really good, well-grown kids who feed their bodies in a way that fits the activity level, where they may be down there on the lower percentiles, but they've tracked it beautifully their whole life. Like it's just who they are. Our concern is more of the kids who start shifting up the colored lines over time, where it's like we might have, been a little on the smaller side, but then, we become less active and we find things like Fortnite and video games, and you'll start seeing those dots climb over time.
Sure. I had to laugh about the coffee creamer because my youngest drinks coffee creamer he drinks half and half all the time.
That's because it's good, Mel.
This is a habit I don't want him to have though, right? Either, because then that equates later in life. But no, my question was more about the growth curve, just because I wasn't sure, if all of our kids are so much heavier, then are they even heavier than we think they are? Because the numbers are just keep getting moved up, but you answered that.
Yeah, no, I certainly think our clothing sizes and the way we shop is certainly changing over time. The numbers that, that we were, like if I had to go back and buy a clothing now that was the same as when I was in high school in the 90s, the size certainly wouldn't be what it's marketed at the store today. That's changed for consumers to feel better about themselves. But I think it's still the World Health Care Organization, and I don't think they're altering it for our U.S. growth curves. But they did make the extended BMI for us so that we can keep going up the chart. So that was kind.
So yeah, my daughter has commented on that because she wears a lot of vintage clothing. And she's usually like a small, extra small, but she's like in vintage stuff from like the 60s and the 70s. She's like a medium.
Oh yeah, I know. I can sure joke that I've worn the same size since high school. That's because the size changes over time.
Not accurate.
Yeah, it wouldn't work so well, but it changes over time for adults. Well, I should say for women. For men, they still, for some reason, have managed to give them an actual number that they use so their clothing is easier to buy.
Now, one thing that is surprising is, so my youngest daughter is, like I said, she wears a small, extra small. She cannot fit in my mother's wedding dress.
Really?
Yeah. So wow. I'm like, Mom, how thin were you?
Yeah. My goodness.
So yeah. Well, thank you. Thank you so much. Great presentation. Good discussion. Really appreciated it. And so I did put the post test and the evaluation in the chat, but you will be getting an email with those as well for any CEUs. And thank you. And I believe in 2 weeks, it is on marijuana. So if anybody wants to join us for that topic, thank you.